And to
Yes.
pivot a little bit to brain mets. And so I noticed in the kind of NRG study, it was looking at extracranial metastases. And so questions for each of you with respect to brain metastases. How do we think about focal therapy versus whole brain therapy for radiation in the context of brain mets? Are there too many lesions? Is there a threshold that you tend to think of? And the second for Dr. Bazhenova to think about while Dr. Iyengar is answering is, how do these new therapies work in the brain? So our antibody drug conjugates, our bispecifics, do we know anything about their efficacy in penetrating the blood-brain barrier?
So I'll take the first question. And I think that it's really amazing. We have moved so far away from whole brain radiation therapy now. And it's because SRS has become so commonplace. Our stereotactic radiosurgery, which is the SBRT of the brain, has become so commonplace. It's so effective. It's so easy for patients. They can be one-day episodic of treatment, and they do really well. And what we've really moved away from is also rushing to treat the brain in terms of Mets, because of what you just described as the second part, which is that systemic therapies are getting better and better at controlling intracranial disease. And so, number one, we shy away from rushing in if the patients are asymptomatic and they're getting a TKI or perhaps some immunotherapy. Number two, the question of, is there a cutoff? My personal experience in group, if there are 20 or more Mets, 15 or more Mets, I offer whole brain. And if there's fewer, I don't. But I've had colleagues who have treated 30, 40, 50 over some time. But, I don't know what the right answer is for that. There are studies that are looking at all of these questions through the cooperative groups and as single institutions. But it's certainly a fascinating area to explore.
Right, and I'll take the second question. So as you correctly kind of alluded to, remember when I started talking about antibody drug conjugate, one of my statements was that this is a very large molecule that is not able to penetrate inside the cancer cell. So initially, we were always very worried about our ability to result in CNS response. But recently, we have two data sets, one from pertuzumab deruxtecan, which is a HER3 antibody drug conjugate, and another one from the HER2 antibody drug conjugate, that it does have intracranial overall response rate. I think HER3 ADC, the intracranial response rate was 33%, which is, I think, in my opinion, is pretty good. Why and how? I don't think we understand fully. Could it be that, that chemotherapy molecule that gets released gets into the brain? Could it be the fact that if the patient have tumors in the brain, your blood-brain barrier is not perfect, and maybe it's damaged enough for the antibody drug conjugates to penetrate? We don't know that for sure, but it's encouraging that we definitely see responses in CNS. I will be honestly, like what Dr. Iyengar said, I'm very comfortable delaying radiation for the TKIs because the efficacy is 80% response rate, 60% complete response rate. I'm a little bit weary in delaying radiation for the antibody drug conjugates just because we don't have a lot of experience. So this is going to be a little bit more of a discussion with the radiation oncologist, and also depending on where exactly those brain mets are. I'll be talking about brainstem, where even like a little growth will mean a lot of side effects for the patients versus like tiny lesion in the periphery, and I can try. But I'm just kind of personally a little bit more apprehensive, if you may, in just delaying radiation for the antibody drug conjugates.
Yeah, I think my practice is quite comparable. And I think it was really a pleasant surprise to see activity of the ADCs.